All of the audiologists from the 70s and 80s would laugh at us when we're talking about the technology that we're using in our clinic today. Hey guys, welcome back to the Dr. Cliff Show. I'm Cliff Olson, Doctor of Audiology and founder of Applied Hearing Solutions in Phoenix, Arizona. And I am joined today once again by Dr. Kelsey Beck and Dr. Rachel Cook. Welcome back to the show, guys.
Thank you.
So we're going to be talking about cool technology, and we're not talking about the hearing aid technology. We're talking about technology that audiologists now use in their clinics to treat our patients' hearing loss better.
Yeah.
Just to give a little bit of a backstory here, I went through my graduate program a little bit before you guys went through your program.
Not that far before.
Yeah, okay, all right. So we were using some really ancient technology down in the basement at University of Illinois.
Yours is in the basement too, huh? So was
They
ours.
know where to put
Mine
us.
was not.
Okay.
You know,
Yeah.
I like to think that it's because it's quieter in the basement. But when
I
you're
just thought they wanted to crush our spirit a little bit. No windows, nothing.
No one cared.
That's right.
I'm just kidding.
What's an
They
audiologist?
We did have like 10 sound booths, and I would imagine
Wow.
that the weight of those, truthfully, couldn't be on any other level. But
Well,
That's interesting.
Well, now that you mentioned that, so the floor, we were on the third floor, I think, but they had to actually redo the flooring in the building, and they actually had to make it thicker in order to support the weight of the
joke.
sound booths. Yeah. So actually, when you're walking up the stairs, there's an elevator as well, but when you're walking up the stairs, you get through like the first couple of floors, and you're like, okay, like stairs, fine. And then that last set of stairs is longer because that floor is actually thicker.
Okay.
Yeah. So like I feel like I'm the only person who ever noticed that, but I was just walking in this room like, why is this set of stairs so much different? Like it hits harder.
Yeah, no, well, now that you mentioned that, now I'm like, okay, yeah, they just stuck us in the basement to like get us out of the way.
Yeah.
Yeah, the construction of it all.
yeah.
Not a single window in the entire place, and you go in on the weekends to like work on a project or
Yeah.
something like that, and you emerge from it and you're like, you don't know if the sun's gonna be out still.
It's like Vegas.
It's kind of like
like
Vegas,
Vegas, yeah.
only much less fun.
Yeah.
So, we were working with some, older equipment. It wasn't like ancient equipment, like the stuff that, you'd think that you'd find in a
Museum.
a museum or something like that. Good point. But it was older stuff, and we used to always have to do things with the equipment that you're like, I'm not sure this is actually going to work.
Yeah.
Like you're hooking up, CD players to your audiometer so you can do speech testing or like speech and noise testing. And it really kind of added barriers to doing our job well.
Yeah, well, even just like old tympanometers, so the pressure test for your ears, not having them integrated with a computer, you're printing out these like receipt-like test results,
Yeah.
and then trying to tape them to a piece of paper to then scan them into somebody's like digital chart and stuff. So I mean, we had those as well, but we had one piece of equipment that was computer integrated, and then all of the other booths had. Or if they had it at all, had like the older versions of them, and we would all kind of fight over the booth when we'd get there in the morning. So whoever got there to the clinic earliest while I was in school got to use the better machine.
Yeah, no, that's hilarious. I mean, I have nightmares, obviously, about doing that type of work, but I think that's why when I started the clinic, we're just getting the most futuristic equipment that you can possibly get, and everything integrates. So I guess my initial question for you guys is, what is your favorite piece of equipment in the clinic and why?
I do need to give this some thought.
I know.
I think that my favorite piece of equipment is actually the Oracle that we use for real ear measurement. The one that I was using, and that most clinics still use, still a great piece of technology, like the VeriFit 2, for example, or even the VeriFit 1 I learned how to use first. Because they're not integrated into, your computer, into your, again, your chart for your patient, we would either like take a picture and then upload the like on our phone and then upload the picture to the chart, or you just couldn't save the results. So you did the measurement, you wrote out in your chart note that you did it, but there was nowhere to like save it and store that information so that somebody else could then, if they had to see somebody else that day, or when I was in school as students, you might see a different student even though the supervising audiologist is the same. So like you can't really look back at what the other person did for any reason.
Yeah, there was a way to make it integrate in a way. You had to take a cable and run it from the actual VeriFit machine into your computer. And then you had to go into NOAA and you had to actually actively go in and click on the module for the VeriFit and pull it over.
You know what? We did actually have that in school now that you mention it, but I've worked at so many other clinics after that my memory of that is a little bit
even then, like, not a lot of
shy.
people would do it because sometimes you have the VeriFit in a completely different room than you want to access the data from, and you literally can't go in and pull it at the time. And funny story, when I first started the clinic, I didn't really spend a whole lot of money right off the bat, so I was buying a lot of used equipment. And so from a test box perspective, I purchased an old VeriFit 1 for like $1,500. And I was like, I have to have this integrate because honestly, the paper, the carbon copy paper thing wouldn't print anymore. So
that's why it was $1,500.
I had to, or exactly, I had to actually connect it with the cable, and it worked for about a year. And then when it stopped working, I'm like, I have no use for this anymore. And I literally gave it away to another clinic who didn't have real ear measurement. And so obviously being able to do real ear measurement even without having it integrated is better than not doing real ear measurement.
Well, and that's the thing is like we just took a picture of it on our cell phone and I would like email it to myself. And the nice thing about the VeriFit is it doesn't have any like PHI, so personal information of the patient. So it's not any like HIPAA violation or anything like that. You just get it off to the computer, then you can save that into that person's chart as well. So there are ways to do it with the VeriFit 1 or older technology. It just takes extra steps to do the exact same thing that modern technology allows us to do.
You know, to add on, because you're talking about real ear measurement equipment right now, when I was in school, we didn't even have the VeriFit 1. We had the Fry box.
I don't even know what that is.
Call it the Fry box. It's like the Fry equipment. So there's a test box with it and there's real ear measurement with it.
Right.
Then you would have to go in and manually enter in the air conduction and bone conduction scores of the patient into the computer. There was no way to port it in from the test that we actually had done. The amount of data reentry that we did, you could have seen 5 more patients in a week.
Oh my gosh. I literally had to copy over so many things so many times. Like you just said, taking their test results and then uploading it into a computer platform, and then taking the same test results and copying them over into the VeriFit system, and then having to take all these paper charts and scan them in. And like the same thing, just data entry alone, I became this expert at like administrative duties pretty much. And then I was like, what am I actually learning about audiology here? I'm getting really good at copying things over, really good at scanning files.
And we've talked a lot about on this podcast as well about time. And the amount of time that you have to then spend to do those extra steps takes the very limited time you already have in a lot of clinics away from your actual patient time. And that's a really big expenditure when you really look at it.
Yeah, and with the insurance dictating a lot of care of patients, basically what that does is it takes time away from the clinician. So now the clinician is trying to still do things at a high level, but if they're not up to date on the audiology equipment inside of the clinic, then it's really hard for them to do all of the things necessary for that patient. Otherwise, they're just stuck as a doctor of audiology doing administrative tasks inside the office that make no sense for them to be doing.
It almost like you need like an extra body. Well, in our case, probably the students, right? When I was a student, I did a lot of data reentry, just because the audiologist had to be doing the audiologist things. But the other things also have to get done as well. So I think it takes some time away from the education from a student perspective as well.
So now we've been talking about the things that we don't like about the old equipment. So with the Oracle probe microphone measurement system, the one that you like, what are explain the process for someone who's watching that maybe doesn't understand why it's so important to be integrated with all this stuff, and then how you would actually administer the test and how you can be so efficient with the newer equipment.
That is quite a loaded question and a long question that has a long answer, so bear with me. So the real ear measurement system, what we do for that is we place probe microphone tubes inside somebody's ears with their hearing aids in, and we can actually measure exactly what is coming out of the hearing aids inside your ear so that we know how much sound you're actually getting. That measurement is then put onto the screen of the computer, and we have this prescription calculated for somebody's hearing loss based on hundreds of thousands of data points of people with hearing loss. We can actually see that prescription on the screen, see where the hearing aid output is in comparison, and then we go in and we can actually make our fine-tuning adjustments with the hearing aid software to have those two lines essentially overlap with one another, which means that you are actually meeting your prescription for your hearing loss. It's very precise, and what I really like about the computer integration piece of that is that everything is just stored in one place. It makes it really easy and seamless, saves a lot of time. But what I also really like about the computer integration is that I can, turn my computer screen toward the patient, show them exactly what it is I'm looking at, what it is I am doing, why I am making certain decisions. And then we can also have the, hearing aid software pulled up next to it, and we can be doing multiple things at the same time. Or if they have a question now about their hearing test, well, 2 clicks of a button, now I can just pull their audiogram back up and we can see everything all together as well. And so it makes it really easy from an audiologist standpoint to be able to switch gears as your patient needs you to switch gears.
Yeah, and there's really no time wasted on data entry, because as soon as you get done with the hearing test in the sound booth, it's all on the computer already. You go back into your room, you pull up their file, you say, okay, well, here's the hearing test. You go over to set up your real ear measurement module, click into there. The prescription calculation is done instantaneously for you. You just have to enter in what parameters, like the age of the patient, experience level, gender of the patient, which prescription you want to use, and it will calculate it for you. And then you get your prescriptive target curves like you were talking about there. And then a year down the road, if you want to go back and like, you know what, let's see how well we matched you back at your fitting. Your prescription has actually changed, so now we need to, this is your old fitting with your new prescription, and we're not hitting it anymore, so you can just go right back in and give them a nice visual reference to do that.
And something more niche for my circumstances is that because we all kind of share offices, so I'm in your office 2 days a week when you're not in the office, and then I'm in your office the other 2 days a week when you're not in the office. So because I'm switching back and forth from room to room to computer, it's really helpful for me to be able to see, my patient's paperwork from Monday. It's just already available to me in the other computer room, because I have to be able to switch back and forth.
The other fun thing about that actually is that we have all of the modules in each one of our office for that equipment set up the same way. So, and you can tell it to be in any way that you want it to be. So we do things a certain way inside of our clinic, and if another audiologist in their clinic wants to have things set up a different way, you can actually go in and save the parameters of how you see the data or what things you're going to test, and it's just ready instantaneously for you.
I think that my favorite newer advance, I guess, in audiology tech would be Odo Suite in general. The idea of being able to integrate a patient's audiogram plus their tympanometry results, if we ran it, plus their real ear measurement results, plus their hearing instrument test box results. I think that when we look back historically and having paper charts and paper records, you were really never able to do things like overlay their previous hearing tests with their current hearing tests to determine how much of things changed over the years. And if you did want to do that, that's fine. You're sitting there with 2 paper audiograms that have your hearing test from initially and your hearing test from today, and you're going, okay, 2,000 hertz, 2,000 hertz. Okay, the right ear was at 15, and now the right ear is at 40. The left ear was at 30, and now the left ear is at 35. And you're trying to go pitch by pitch, ear by ear, of this old test to this new test. Whereas now, we have every hearing test that they've ever had in our clinic, and we can layer them over each other and go, oh, where was this major change? Oh, you know what? Actually, it was between this time and this time. What happened? What changed with your health between this window and this window? Oh, you had a stroke? Oh, you had a heart attack? All right, well, that makes a lot of sense. Like, we can use all of this information, and I don't have to go search here or there or search through printed records, even go through their chart in Counselor, which is our patient management software system. I don't have to go through all of that. I have everything that they've ever had done at our office in one spot. And it's like the Bible for that patient.
Yeah, and it's cloud-based too, so you don't necessarily have to have a cable running into every room, into every computer, which would just be a networking nightmare for that. We have test box in the workroom, right? And then you have, the audiometer in the sound booth room.
Right.
You have real ear measurement equipment in the provider's room, and it all is just all together at the same time. So I think my favorite new technology or technological advancements from an audiology standpoint is the hearing testing. But not just the hearing testing, how we can present it to a patient. So from the standpoint of, we go in and we do everything PC based. So you're running the hearing test like you were mentioning. You get all of the proper color coding of left and right on this audiogram. It's in the computer. I'm not making an error when I'm writing it down on the audiogram and be like, oh shoot, let me scribble that out and make the X in a different spot. And then I have to go back in the room and present it to them on this scribbled on sheet of paper to help them understand really what their hearing loss is. I can just save it. It's all nice and clean. If I made an error or made a change, it just digitally changes in the audiogram. So I take it back from, and that's what the Natus Austera 2 that we use as an audiometer inside the sound booth. And so then I save it, I go back into my room, I pull up their audiogram on my screen, and not only is it perfectly, perfect to see on the nice big computer screen instead of a really small piece of paper that's, been copied too many times so you can't even see the lines of the decibel of hearing loss. So it's up on the screen and I can take things away, I can add things, I can remove the bone conduction scores so it doesn't take away from the visual of the air conduction, the X's and O's on the audiogram. We can overlay the severity of their hearing loss on there to help them conceptualize that. We can overlay the speech sounds on the audiogram, and then we can do a grayed out area to say, hey, these are the sounds that are not even making it up to your brain anymore. And then we can explain the sounds that are still making it up to their brain to help them understand why they're having difficulty with certain people's voices or understanding speech in certain situations. And just having the overlay capability is massive in my opinion.
Yeah, the counseling aspect that comes with having the ability to separate out the ears, to overlay old audiograms, to bring up the speech sounds or the different severity ranges, and it's all so fast. And so we're just popping this up and then we say, well, this is related to this and this is related to that, and you can demonstrate everything. I feel like people just have such a better understanding of their hearing and where their difficulties are coming from and what that means for treatment recommendations moving forward when we can present it in that manner.
Well, and we're also not taking all of that time to handwrite things out, to do everything by hand, that data entry, all that time that we would spend doing those things. We now can spend that time doing the counseling aspect, which is the thing that really needs to happen from a patient perspective, which, again, saving the audiologist all that time. And I hate to use this phrase, time is money, like we all have heard that phrase, but really time is that thing that is the most valuable when we're talking about, explaining an entire auditory system to somebody who quite literally has never thought about their ears until that day.
Yeah.
So it's no shocker that the three of us, all of our favorite things are things that save us time in the clinic with the newer equipment. So let's talk about how the new equipment helps us do our job better. Rachel, you were telling me a story, or telling us a story about a patient who had gone in to have some earwax removal done. So how did video otoscopy and other forms of tech inside the office help out with that patient?
Goodness. So I have this patient come in yesterday and everything's going well from a hearing perspective, but he says, I'd really like if you take a look in my ears. And I said, I do that every time, don't I? And he goes, no, today's different. And I said, whoa, what's going on?
Was this an established patient of ours? Okay.
Yeah.
Oh, okay.
Yeah.
Go ahead. Sorry.
He tells me that he sees his primary care, and his primary care says, you've got some wax in your ear, let me take that out. And first of all, I'm just like, okay, if he had any wax in his ear, it'd be very, very minimal, because I just saw this patient a few months ago, and I clean his ears out every single time I see him. But he says that he takes some sort of tool, digs around in there, says it's the most painful experience ever, says he immediately puts his hand up to his ears and there's just blood just pouring out of his ear. And his doctor says, oh yeah, ears are sensitive and it'll be fine, you'll be fine, it'll stop later today. This was nearly 3 weeks ago and he's still experiencing some lasting pain and discomfort from that. Said he couldn't even hear for a few days because he believed that the blood had pooled up enough in his ear to completely occlude his ear. And then he said, but it opened up and I can hear now. I just want to know if it's all out of there or not. So we get to use video otoscopy for this. And so for those that don't know, otoscopy is just when we use our tool to take a look in your ears. Nearly every person has had an otoscope placed in their ears at one point or another to take a peek. And we have standard otoscopes in the office, but we also have video otoscopy. And what this allows us to do is take what we're looking at in their ears and actually put it up on the computer screen and show them, because many people have never seen what the inside of their own ears look like. I don't really know why you would, right? But there are certain instances, like in the case of serious infection, where I go, you got to see this. Or when I find a couple of domes stuck in someone's ear, and I go, no, there really is a dome in your ear. Let me prove it to you and show you. Well, in this case, I got to use the video otoscopy to show this patient what all had happened in his ear canal. And the first thing I see is just this wall of deep red black, which generally means dried blood. And it is nearly blocking his entire ear canal, almost 90%. I can get a little tiny bit of visualization up at the top, but otherwise nearly completely occluding in there. So this patient had had some pretty significant damage done in getting this earwax out. Luckily, the eardrum was fine, but after I had removed some of that dried blood, the ear canal had been rather banged up. And it was a really powerful moment because the patient said, that guy's never touching my ears again. You're the only person that's ever touching my ears again. I said, that's a pretty good plan, because if you don't have the tools or the equipment to really visualize what you're doing, you can do a lot more harm than good.
What did you do to actually clean out his ears?
Well, I ended up using, we have some headlamps and loops in there, and I did end up using a curette in this instance because I didn't want to introduce water because I didn't know if there was still an open abrasion in that ear or not. So I was able to pull that out pretty easily.
Well, and you still don't know either if the provider that he had seen ruptured an eardrum.
Yep, right. At this point, I can't see beyond
you can't
there.
See.
I could have run a tympanometry measurement, but using the curette, I was able to take that out, realize very quickly that the eardrum was completely intact and that the damage was in outer ear canal issue. But
were you able to use the video otoscope to also take pictures and save those pictures of the damage as well?
Oh, sure did. Send them right over to the patient, and I said, you can do with these what you'd like, because he said, I don't know if I want to bring this up again to my provider. And I said, well, here's the pictures so that you can at least say, hey, this was my experience. This is what happened to me. Maybe I don't want to take this any further, but just know you can't just be digging around in there and not seeing what you're doing, because here's what I was left with from that interaction.
That's something that makes me super nervous about these like at-home earwax removal kits as well. Even the ones that do have like the cameras that are attached to it, the depth perception that you get with those is absolutely horrendous. And the ear canal is a really sensitive area.
So
and to just go digging with anything, you know, even a cotton swab, the amount of damage that I've actually seen recently with cotton swabs, I've seen several people, I'm looking in their ears, I'm like, you do have a scab in here that has these like striations, which is often associated with the cotton swab because it does have like it does leave scrapes on the bottom of the ear canal. And I've seen actually like 3 people in the last 2 weeks or so that have all had abrasions and cuts from just cotton swab use, and it makes me so nervous that other providers are just kind of digging for gold, really, in your ears.
And if you don't know what you're looking at, if you don't do cerumen removal, earwax removal regularly as a provider, it's very good to do it well to where you're not hurting a patient, because that is not a normal experience. So anyone watching this and is like, oh my gosh, I don't want anyone to ever clean out my ears, like that's not how it's supposed to go. You just have to go to someone who this is what they do, right? And I kind of sympathize with the primary care physicians and all that, because they probably don't do a lot of earwax removal. We do it 5 times a day on patients. And when we're talking about the technology, so I love the video otoscopy aspect of looking in their ear, seeing what they have earwax-wise, seeing what they have, if there was a hole in the eardrum, being able to take an image of it, show it to the actual patient so they can see what I'm seeing and I can counsel them better based on that. But I have to say that here, when I first started my clinic, I had only curettes to remove earwax. I didn't have anything else. And I had patients come in with completely impacted earwax inside of their ears, and I was just not able to get that earwax out completely. And yesterday I had a patient come in, no complaints of an issue with her ears, with earwax or anything like that. She's like, I use Q-tips, it's not a problem, they work great. I look in one of her ears and I can see this impaction inside of her ear, and I'm like,
wall of wax.
And she didn't believe me, so I had to show her on video, see, like, this is what you're doing with the Q-tip. You're not hurting your ear, but you're packing in the earwax, and it went all the way down to her eardrum, so I couldn't use a curette to pick it out. And irrigation, for like a lot of clinics who don't do earwax removal a whole lot, so primary care physicians' offices, right? They'll take a syringe. My grandmother had earwax removal done. They took a syringe of water that was cold.
Okay.
They blasted it into her ear. What did that do to her?
Did she vomit?
Oh, I bet it made her spin like
She
crazy.
was as dizzy, she was dizzy. It had like a lingering effect. I mean,
Yeah.
she's in her 80s. She had a lingering effect of dizziness for days after that, because for those of you who are unaware, when you introduce cold water into one ear but not the other ear, it creates this convection effect of the fluid inside of the vestibular semicircular canals, and your brain gets mismatched signals of movement. So what does your brain do? Well, it makes you feel dizzy because of that. And they didn't actually even get out the earwax.
Oof.
So there's been a new technology that was invented called the irrigator.
So the best pun in all of audiology.
Yeah, it is. It's pretty great.
You plug it in, you have it set to the human ear canal body temperature, and then when you go in and you're actually irrigating out, flushing out the ear in a very controlled way, it doesn't create any dizziness, and you can control the amount of pressure that you're using instead of just using a handheld syringe where you have no control over that.
Yeah,
Or
it is
minimal.
the best. It is the best, because a lot of people will say, well, okay, fine, you look in the ear, it's completely occluded, and why can't you just use the curette? Well, in certain cases, you can just move some of it out, but the problem is that we're really trying to get a visual on the eardrum and the tympanic membrane. The tympanic membrane is extremely thin and delicate. It's almost as thin as a single strand of human hair. So we can't just be poking around in there, because one wrong poke when we can't see what we're doing could lead to disaster. So in those cases, being able to use irrigation, to use some warm water with some gentle pressure, loosen that up and move it out of the ear without having to use like tools. And then at that point, you're able to look in and go, oh, okay, now I've got some visual of the eardrum. Okay, I can use a curette for the rest of this, because now I know how far I can go. But without that information, you can't be doing that. So the irrigator, oh, it's my favorite ever.
Well, and the other piece of that too is that, I don't know how this happens so frequently, but, earwax builds up over time. And oftentimes it's so hard because it's been there so long, and it really is like sealed
It is.
with the ear canal. And like we said, the ear canal is a sensitive area. If I start tapping on something and really like I'm peeling it off the canal wall, that's not a comfortable experience.
It's like a Band-Aid getting ripped off.
But you have to do it slowly, because again, you're trying really hard not to disrupt the eardrum.
Right.
And so to pick that out can often be really painful. And even with the irrigator, sometimes there's been wax that's just so hard and has been there for so long that we're doing rounds of irrigation. We're doing rounds of Earwax MD eardrops, which, by the way, if you've never used Earwax MD to remove earwax at home, literally my favorite product that has ever been invented. And we're doing this multiple times and like really pulling it out layer by layer as we can loosen it up. So really, like, having the equipment and the tools that you need for something like that is so important. Even something like suction, which I feel more clinics have than they do like the irrigator, but utilizing suction for very specific types of earwax is actually the safer option still than going around and using a curette and doing it that way as well. So having all of the tools needed to treat each different type of earwax is really, really helpful.
For sure. I would have to say to switch on to a different piece of equipment that has really helped out a lot is the test box. So I think that's probably the most underutilized piece of equipment inside of an audiology clinic. The Oracle Hitbox is the one that we use, and it allows us to run a diagnostic test on a hearing aid to see mechanically how it's functioning. And you can't test the hearing aid any other way than this. Like when you're doing real ear measurement, you're like, oh, well, I could see if there's a problem with the hearing aid by running real ear measurement. Setting everyone up to do real ear measurement if they have a reported complaint takes longer than going in and running a hearing aid through a test box where we're putting a calibrated signal through the hearing aid and we're measuring the output of that device to see if it's meeting manufacturer specifications. And we've had patients come in having issues with their hearing aids that we would not have been able to identify unless we had a test box to actually run it through that calibration.
Well, you actually had an interesting case around the test box as well, if I remember correctly. Someone had been to a different audiologist, maybe even several audiologists, and had undergone other testing and things like that because he wasn't hearing very well. And if I'm not mistaken, they recommended him for cochlear implants. Was that correct?
Yeah, I'll take you through it. So this patient was a patient of mine for 4 years. He's a snowbird, so goes up to Colorado for part of the year, is back down here in Arizona for part of the year. So I had ended up treating him initially about 4 years ago. Very difficult hearing loss to treat. Had some good low frequency hearing, but it gets bad really quickly in the high frequencies, and then there's definitely certain frequencies that you just don't want to amplify because it ends up sounding like garbage to him. So at the time, I'm like, well, you may actually want to go get a cochlear implant evaluation. He's like, I really don't want to go that route. You have me hearing really good, better than what he thought he was going to be able to hear with his hearing aid. So he's like, I'm going to ride this as long as I possibly can. So over the course of the next 4 years, he's been happy with the way he's been hearing, but he ended up, I tested him right before he went up to Colorado for the summer, getting the heck out of Phoenix, Arizona, because it's so hot here. And he did well initially, but then about midway through his time in Colorado, he started to struggle with his hearing, and he's like, I don't know what the heck's going on. So he went into a provider in Colorado. They tested him. They were able to look and see, well, your testing is very similar to the testing that he had done when he was down in our clinic in Phoenix, so no change to his hearing. And they're like, well, let's just turn up the volume a little bit in the devices. Maybe that's the issue. It wasn't the issue, still struggling, so they recommended that he go to another clinic to get a cochlear implant evaluation. And they use his hearing aids to take him through the testing. So if you're not familiar with cochlear implant testing, you have to be in your best aided condition going through that test. And if you score poorly enough, you're a cochlear implant candidate. And so he went through the testing with his hearing aids, and he was a candidate. But he started doing some research on cochlear implants. He's like, I think I'm going to do it, but I really want to go speak with Dr. Cliff Olson, my regular audiologist, before I go do anything. So he comes in, and we spend literally the first half hour of his appointment talking about cochlear implants, because I'm thinking like, okay, well, he's finally there. He's going to do this. But the stuff that he was saying just didn't make sense. Like, he went in, his hearing was the same. They turned up the volume on his hearing aids. Shocker, that didn't help. He got approved for cochlear implant. I'm like, okay, well, they would have put him in best aided condition and confirmed that his hearing aids were functioning the right way, but it just didn't sound right to me. So I did a listening check, and I'm like, I don't really notice anything out of the ordinary with the listening check, because remember, I'm only really amplifying low frequencies on him. I'm not amplifying high frequencies. So it sounds completely different when you're amplifying sound in that way. So of course it doesn't sound like a perfectly normal hearing aid, but I still didn't know the hearing aid was malfunctioning. I go on to run test box measures on both of the hearing aids so I can get an objective measure of how the hearing aids are actually performing, and both of them failed horribly. Not just a little bit out of specs, massively out of specs. And he used those hearing aids to go through his cochlear implant evaluation to get approved for the cochlear implant. And instead, I was like, okay, the hearing aids are malfunctioning. Let me upload your exact same settings into an identical pair of loaner devices. And I put them in his ears, and he's like, oh my gosh, my hearing's back. And he's like, you're telling me that I could have been hearing this way with the hearing aids, but I was almost going to get a cochlear implant for this? And that just goes to show, like, imagine if the test box didn't exist. He would have potentially gone through a cochlear implant procedure that he did not need.
You can imagine that if it didn't exist, because it doesn't exist in many offices. So it's not even a hypothetical.
Used.
It does exist and it isn't used, or it doesn't even exist in someone's office at all. So they're using their own subjective determinations of, well, I listened to it and it sounds okay.
Well,
you know
and
how
you
many
listen
hearing
to
aids
it.
I've listened to that sound okay to me, and then I run them through test box measures, and I'm like, okay, maybe I got to get my hearing checked because it's completely off.
Well, the other funny thing is that sometimes it sounds like garbage to you.
Oh yeah,
And
sometimes.
it's perfectly
But
functioning.
it's perfectly functioning fine, because their
For them.
hearing loss is unique to them,
Yeah.
and the way that they perceive it is different than the way that we'll
Yeah.
perceive it.
Well, and recently I had someone who came in who had never complained about, fan noise and stuff, but hadn't tested his hearing in a year, just was like, yeah, no, for whatever reason, there's just a lot of fan noise, and that's just really bothering me. We did move offices too, so maybe it's just this new office, this area, like, I don't know. fine. We went through all of his hearing testing. Nothing has changed. Word recognition. All of it is exactly the same, like to the letter. And I'm like, well, okay, I'm going to take your hearing aids in the back. We're going to do our test box measures. Just make sure that everything is functioning well. What most providers would have done would be skip the test box measure and go right into the software and said, okay, well, soft noise reduction for fan noise. I'm just going to kick that up and that'll go away. Well, it wouldn't have, because when I ran it through, the equivalent input noise, so how much noise the hearing aid generates just by being on, kind of like your car idling, was like 42 decibels or something like that. And there was no way any amount of programming was going to take that fan noise away, because it just sounded like fan and static. And when I even listened to it, I was like, the air conditioner in here is not on.
Yeah.
And I heard it kick on while I was listening to it, and I was like, it sounds the exact same. So I got an inkling that there was something going on, but quite literally most people would not have even listened to the devices, wouldn't have run it through test box, would have gone straight into the programming, kicked up some soft noise reduction, and sent him on his way. And he still would have been having this massive amount of noise in his ears for no apparent reason.
Yeah. An unoccupied room in general, if it's a completely quiet room and you don't have like a noisy AC or anything on like that, sits at around 35 decibels. And when we're testing this equivalent input noise, or the idling of a hearing aid, we're looking at for it to be at around 20 decibels or lower than that. So 42 is already louder than what a neutrally quiet room would be at.
Yeah,
no wonder.
Yeah, and I mean, and that's also a precursor to other malfunctions happening in the hearing aid too. Like it can be a sign. So even when we identify that a hearing aid is just a little bit out of specs, it's one of those things where you want to keep an eye on it. Either you get it fixed, even if it's a little out of spec, or you keep an eye on it because it's like, okay, this usually means that something else is going to go wrong with the hearing aid. So we can either be proactive about it, or we can be reactive about it. And in our clinic, we like to be proactive
about it.
because,
especially if they're in warranty. I mean, if they're in warranty and I have a set of loaners, let's just send it off. Let's not wait for it to become a problem.
You saw it yesterday with my patient, running test box measures. OSPL 90 and full on gain are just slightly out of specs, but if he's in warranty and we can replace the receivers without any issue, why would I have him be slightly out of specs when he doesn't need to be out of specs? I'm going to do what I need to do to get his hearing aids mechanically functioning the way that they should be all of the way.
and I guarantee you that you listen to that hearing aid and you would not have picked up on that at all.
Gosh, no.
But you can objectively see it when you measure it on the computer screen.
Yeah, you saw me sitting there going, I don't know, and then you came over and you're like, yeah, just switch it. Let's just switch it,
And then, it ended up being
But
better.
listening, I would have said, these sound exactly the same and they sound great.
Yeah.
There's a lot of value that comes from subjective listening checks, because a lot of times we can hear when things sound off to us. But alternatively, we also miss a ton on those subjective listening checks because we're not the ones with the hearing loss. And we need these objective tests to really fill in the gaps, the missing information, and make sure we've done our due diligence and making sure, yes, this equipment is functioning the way that it should.
And if I was only listening to one person's hearing aids like every 3 months, I would probably be able to detect something going wrong in that sense. But I listen to like hundreds of
Full
hearing
spectrum
aids.
of them, yeah.
And so to know what one person's hearing aid sounded like 6 months ago, and then again when I see them 6 months later, or whatever that time interval is, it's hard. I mean, I'm listening for like the big issues, so big amounts of distortion, big fan noise that shouldn't be there, like making sure that nothing's cutting out if there's any like sizzling bacon sounds. So the big things that could be malfunctioning, but these small things, just like hearing loss happens so gradually over time, so do these malfunctions most of the time.
They do.
So people come in and say, yep, no, I'm hearing great, there's not a problem, and we run it through and the distortion is at like 7% instead of well below 4%, which is where I'd like it to be. Heck, I'd even like it to be well below 2% if I have the option.
Yeah, I measured one yesterday that was at 0.2% distortion
yeah.
at all of the measured frequencies.
I
I'm like,
love
yeah.
it.
I don't know if I've ever seen him that
Yeah,
well.
you
three
guys
of
are
them.
nerds. You got excited by that.
I mean, that's pretty good.
Huge nerds.
That is pretty good.
That's awesome. So we've been talking about some of the tech that we do like. I would just like to quickly talk about stuff that like old equipment that we just hated. And I'm going to start.
Okay.
The piece of equipment that I hated to use, and I had to go back to, I was back in school when I had to work with this, was doing speech and noise testing from a CD player that would skip if you breathe,
Yep.
right? If you would breathe in the room that you're running that on, it would skip. And so it would take forever to run through a speech and noise test that's supposed to take like 4 minutes, right? And I can just remember being like, this is dumb. Why don't we have equipment that doesn't require us to do this?
Yeah. Oh yeah. God forbid you hit the stop button instead of the
accident.
pause button too, because
starting all
when you
over.
press play, it's start your list over again, and trying to fast forward and rewind and find the exact sentence that you were on, and what a mess! What a mess!
And
All the
heaven
different
forbid you had the
lines.
wrong source of the
You had the
audio.
wrong source.
You click the wrong button, so it's not even playing from the CD player, and they're sitting there
Or
and
it's
you're
playing
running
in
the
one
test.
ear, and they finish the whole test, and they go, "That was just my right. Are we gonna do my left now?" And I'm like, "It was just your what? Like what? We
Or
just
when
did
you're
this."
trying to play like noise in one ear and then like speech in the other ear, and they're like, I said the sentences, I did the sentences, but there was no background noise. I'm like, well, what do you mean? I was like, that's a
The
background
noise was over here, and you're like, "Oh."
Yeah, and you have these like big panel with all these buttons and words
Oh,
on
I
it.
felt like a DJ. I'd be like in the booth, just like, well, okay, do you hear it in your left ear? Okay, cool. Raise your hands if you do.
That week
Yeah,
I start
you know?
the test 15 minutes late because I'm still trying to figure out.
Gosh.
Yeah.
I mean, I'm very, very happy that these days most of our controls are limited to a standard keyboard, because really I felt like an audio mixer. Like I was like, click this on channel 1, input source B, into the left ear, masking in the right. And I was like, why do I feel like a rocket scientist right now? Like, this
Yeah.
is not fun.
And there are so many buttons on those audiometers.
So many,
I mean,
and they still exist on the computer-based
Yes.
ones, but you can at least see everything in one.
Yeah.
So on our, on the Austera, all of the controls are on this left panel, and they're really clean. They're segmented out. Your source, your ear, your noise, your inputs, your transducers, all of these things. Whereas on these bigger audiometers, they're just spread out all over the place, and maybe there's an indicator light when they're on, and maybe not. And you're just sitting there like, oh, is everything on perfect? I had so much anxiety in my
yeah.
program. I was like, is everything on where it needs to be?
we had an audiometer that wasn't in any of the clinic booths, but one that was in like the practice clinic booth, and some of the lights just didn't work, or like there was a very big delay. Like you'd click like your noise, but then you'd have to like count to like 5 before the noise started playing. So you'd even like set it up the right way, and still something wouldn't be quite right, or there was or it was mismatched in some way. And so the ability for the computer to handle all of that really seamlessly is above and beyond.
That's hilarious. I did a speech test for a 5-year-old, and that kid was deaf. But he was deaf because I didn't actually present him any words. And I thought I was. I'm like, okay,
like,
he's not even
man,
hearing this. Poor
nothing.
kid's deaf.
Yeah.
And turns out, nope, kid hears fine. I just don't know how to do my job
Kid hears
because
fine.
the equipment that I'm using is from 1972.
Oh my gosh. Oh, not to mention that the VRA, so the VRA stands for Visual Reinforcement Audiometry, that we often use on children because they're not going to sit there and go, I heard the tone. Okay, do it again. I heard the tone. They're not going to do that, but they will turn their heads to certain sounds to look at them, and then they'd be reinforced with these dancing toys. And I don't know about your guys' VRA systems, but we had the creepiest monkey with cymbals that would go
Something straight out of a horror movie.
These kids would look with fear deep in their souls, like, and I'd be like, this is not working. This kid would walk out of the booth just like crying and traumatized. I think the other corner had like a clown that would dance
that's
around,
even
and I'm like,
worse.
who made these? I think these days a lot of pediatric audiologists use screen-based VRA that has like Paw Patrol and
Mickey Mouse.
Mickey Mouse
Yeah.
and stuff. But I don't know who decided on those. I'm still traumatized from them, and I wasn't a small child going through
Well,
that.
that's like when you watch like like a horror movie that's set like in the 60s and 70s, and they're just walking around with these dolls that were completely like time related. Like those were the dolls of the time, and I'm looking like that's what nightmares are made of.
Yeah.
Like that's why that's like time period works for horror movies so well. Like the Conjuring series, for example, that's why it works so well, because those toys are terrifying. The baby dolls, they look possessed. I don't care if it's never been possessed, it looks possessed. So that's kind of how I felt with some of those VRA toys. I'm just like I would be scared.
Yeah, they were spooky.
I as a whole adult do not want that thing turning on.
Yeah.
And what's really creepier is that a lot of the places will have the lights in the booth dimmed so that when it lights up, it gets their attention. And I'm sitting on the other side,
it's
and
just
I
this
can see
haunted
that
monkey
like
now.
it's terrifying.
It's dark in there, and then all they turn and look at is just this like monkey thing in the corner.
All right, real talk here. So that's the reason I don't do pediatrics, is because I'm scared to death of the VRA systems that are out there.
Fair.
No.
I don't blame you.
Perfect example, though, of getting with the times and upgrading the VRA equipment to something that will gather the attention of the test recipients without traumatizing them for life.
Well, the idea is that it's positive reinforcement, right?
Yeah.
Ain't nothing positive about that creepy monkey lighting up
Heck
in the
no.
dark. No.
I find this hilarious because obviously we are younger audiologists, relatively speaking, inside the profession. If I just had Gus Mueller on the show, if I were to talk to him about complaining about the tech that we had from the early 2010s, he would just laugh at
He'd
me.
be like, "That was my favorite. What are you talking
'Cause
about?
he
That
was
was the best I had seen yet."
He was
you know?
around when real ear measurement was just being developed, and the size of that equipment and like how it actually worked. There was no such thing as integration of anything ever.
Was there even a computer?
Like they had computers, I think, to some fashion.
Pretty basic at that point, but
Yeah. Yeah, and it's just any audiologists watching the show are like, you guys are soft.
Yeah,
You know,
I'm
you
sure.
guys-
I'm
100%.
sure, yes.
I've never programmed a hearing aid using a screwdriver, so that right there automatically disqualifies me in the mind of many audiologists who are like, you weren't there when it was
Yeah.
super tough.
I'm
Yeah.
sure
I'm
we'll
like,
talk.
I got my new tough. I'm explaining the difference between Bluetooth and Wi-Fi every day, okay?
Every day.
So it's a different tough.
That is a good point. Like, we have to deal with so much more stuff
Yeah,
than what
way
they
more
had
tech.
to back in the day.
Oh my
3
gosh.
trim pots is all they had, back, or maybe less than 3, depending on the hearing aid technology
I'm
level.
working with every type of iPhone, Android, app interface systems, accessory devices, assistive listening devices, every hearing aid from every manufacturer with different styles, different makes. Like, it is still hard, if not maybe harder. I don't know, someone's going to come at me for saying that. But it's a different type of hard.
Yes,
I'll say
different
that.
type. Well, and that's the thing too. I mean, the difference between Wi-Fi and Bluetooth, I mean, that conversation happens daily. And I will never understand why that this is such a hard concept to not only explain, but to also understand.
Because it doesn't exist.
Yeah,
you
because
can't
it's
see it.
like
It's not
the, like
tangible.
the cloud, for
I'm
example.
explaining, it's like I don't know, Matthew McConaughey when he's talking in, what is it, Wolf of Wall Street, where he's like, it's fairy dust, it's nothing. Like, he's sitting there, Bluetooth and Wi-Fi, I can't like pull down the Wi-Fi and show you.
Yeah.
Like, I'm saying, okay, so things happen in the air. You can't
It's
see
invisible.
them, and you just gotta
trust
me.
me.
And like, it's a difficult concept.
Yeah.
I think 20 years from now, it's not going to be as much of an issue anymore because at least like my grandparents who are in their like mid to late 60s right now, they're really understanding Bluetooth and Wi-Fi now. So I'm like 20 more years and that won't be a thing anymore.
Well, and at the very least, too, because at least, especially with our generation, right? Like, we all grew up with tech in some way. So even as tech changes, we're not learning a whole new language every time something new comes out. Whereas, utilizing an iPhone from only having like a voicemail that had a cassette tape is a huge jump in technology, and we're asking someone to learn a whole new language with their tech in addition to with their hearing.
Yeah.
So we ask a lot of patients nowadays that wasn't always necessary. And so again, just different hard and different amounts of hard and time and energy that are spent elsewhere. But there are also still clinics who do all of that and have paper charts and have paper audiograms and have the TIMP star that has to print out your little receipt of the their thing that they have to tape on and scan. Like, there are still clinics who are doing what we're doing without all of the advancements in technology as well.
God bless them.
Right?
Yes.
I mean,
I
the amount
know.
of time that it has to take to get all of that done and done effectively either is a lot or things are being skipped.
Well, I'll tell you what, let's redo this episode in 10 years, and then we'll talk about like the new innovations in diagnostic testing
yeah.
equipment and all that stuff, because
We
we'll
will
probably look back
laugh.
and like, man, we had it rough
Yeah,
back
right?
then, right?
That was brutal.
But awesome. I think we're actually going to be doing an episode where we're talking about the hearing aid technology advancements here soon, but we will save that,
Yes, we
obviously,
will.
for another episode. Guys, I hope you enjoyed this episode today. If you did, make sure that you hit that like button, and if you are not yet subscribed to the channel with notifications turned on, go ahead and do that as well. And as always, we will see you next time.